Hello again. Welcome to another session of Surgical Pathology, Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and this again is a service made possible by the collaboration between the Digital Anatomic Pathology Association, Digital Anatomic Pathology Academy, which is a service of the Digital Pathology Association, Path presenter. A little bit further into gynecologic pathology and cover a less common tumor in the ovary. This is a unilateral mass that was discovered in a 45-year-old woman on routine gynecologic exam. Ascites, it was of moderate size, about 8 centimeters, and not particularly symptomatic. So a view of this lesion, which was partly solid and somewhat spongy, had some cystic areas as well. Here we can see a sort of lobulated configuration, sort of some polypoid or papillary-like areas interspersed with glandular spaces and some fairly eosinophilic stroma. We also note that there are some cystic spaces which are not particularly complex. So we'll look first maybe at those spaces and just take a look and see what is going on here. Certainly, cytologically, these look fairly bland. It's hard to tell right off whether this is ciliated epithelium or mucinous, maybe a combination of the two. As you see, not much in the way of atypia, and the stroma surrounding is quite dense and fibrotic. And here we see more of this sort of columnar type cell, a few of them then starting to be back to back, and so forth. So moving on to the more complicated areas, we'll take a look over here. And we see a couple of features right off the bat that strike us. One is this sort of streaming spindly shaped stuff in the stroma epithelial interface, as well as this glandular component. So this looks a lot like the kind of squamous metaplasia that you sometimes get in the endometrium in cases of hyperplasia or low-grade carcinoma. And clue right off the bat that this is not our usual tumor, but rather probably an endometrioid tumor. Looking a little further, we can see that these cells do have a bit more of an endometrioid type of appearance, sort of columnar appearance. And again, we're not seeing too much in the way of atypia, but certainly the glands are somewhat more crowded than you would expect. And in many ways, they're very reminiscent of an endometrial type of hyperplasia, if you will, with this squamous metaplasia going on in the background. Looking all through here, we don't see any particular areas of high-grade morphology. We don't see any necrotic debris in the luminal secretions. So this looks like a fairly low-grade or benign process, but it does have this architectural complexity. So we know this wonderful border, and that may be where this best fits. But another section, we again see a similar pattern recapitulated, some areas of larger cyst formation, this more spongy, solid, and papillary polypoid type stuff. Let's take a look here at this area and see if this provides a further clue. Here we see sort of a fibrous wall and some of these foamy or dirty hemosiderin-laden histiocytes. So this is quite reminiscent of endometriosis, isn't it? And that finding, in conjunction with the other findings we've seen, is fairly common. And certainly this is an endometrioid tumor Obviously, endometriosis is a very common event in the ovary, and on occasion is associated with the development of an adenofibroma, which may be benign or, as in this case, may be tending towards the borderline category, sort of intermediate and approaching of hyperplasia. Look again at another slide, again seeing this at low power, this low area, or this cystic area lined by hemosiderin-laden macrophages, no epithelium, again suggestive of endometriotic cyst, but with the backdrop of a very fibromatous type response. Here we'll see some of the other degenerative changes, cholesterol clefts that can be associated with this as well. And our last slide of this entity, we again see the mixture of this spongy, solid, and cystic areas, larger cysts with the suggestion of cholesterol clefts and maybe endometriotic changes. And we do see in association with these cells not really much in the way that we would call true endometriotic stroma. So this really isn't what we call endometriosis in the sense of this portion, because we don't have endometriotic stroma, but we have endometrial type epithelium with squamous metaplasia seen nicely here. Now, if we were to need to consider that, and certainly these cells we would expect would endometrium with CK7 positivity, PAX8 positivity, strong hormone positivity. Of course, most of the keratins would be positive. And we would not expect to see of W1 or mutation markers for serous low-grade or high-grade lesions. There are clear cell lesions of this type that may be mixed in and so forth, but we, in the absence of seeing any now, would certainly not want to classify it as a clear cell lesion. And of course, with the squamous metaplasia, our P40 and P60 markers could be seen variably. So just to contrast, go on and just think back to a case we looked at earlier and look and see how the architecture here of this papillary borderline tumor is different from what we just saw. You see the complexity of the architecture is greater. The bulbous papillary projections that we occasionally see in serous tumors is what we're seeing in the endometrioid tumor. And going the other direction in terms of developing full-blown carcinoma, endometrioid carcinomas will have, frankly, malignant epithelium with gland formation and more high-grade nuclei, mitotic figures, and so forth, as we see in this case. So our diagnosis for today's case is of a borderline endometrioid adenofibroma presenting in the ovary. Has striking resemblance to some of the features of endometrial hyperplasia with occasional squamous metaplasia as well. Okay, thank you for joining me. I hope you've enjoyed that. And if you have any questions, please feel free to reach out to me either at my email or my Twitter feed, and we will look forward to spending some time with you on surgical pathology again sometime.